Hello, here we're looking at a segment of the large bowel, and this is the mucosal surface, which is a little bit abnormal, and here is the serosal surface. So most of the pathology is visible on the mucosal surface, and we can see here that there are several openings. For example, here, here, and a few others here, and even in this region. These are colonic diverticular, and this condition is known as diverticular disease. I'm not able to show you a cut section of the gross appearance, but let's have a look at the microscopy. This is a low power magnification view of the microscopic appearance of a single diverticulum. So this is the normal bowel wall over here with the mucosa, submucosa, muscularis propria, and subserosal tissue. If you follow the mucosa, you can see that it dips into the wall of the bowel, and here it's coming out again to the normal part of the bowel. This is the diverticulum, and the wall of the diverticulum actually does not comprise the full thickness of the bowel. Hence, this is not a true diverticulum. This is a pseudo-diverticulum. What we have is the mucosa, the submucosa, and a little bit of the muscularis mucosae. Sometimes a thin attenuated layer of muscularis propria can be visible, but beneath that is directly the subserosal fat. So in most instances, these pseudo-diverticula only comprise the mucosa, the submucosa, and sometimes a layer of muscularis mucosae. Because the wall is very thin here, and because of the structure of this diverticulum, food can get trapped in here, or fecal material, and this can give rise to obstruction and inflammation, and potentially perforation with pericolic abscess formation. In addition, there can also be fistula formation, for example, between the colon and the bladder, colovesical fistula. Patients with diverticular disease may be asymptomatic, or if there is an inflammatory component, they may experience pain. Sometimes they may also experience some degree of colic and even GI bleeding. So how do diverticula actually form? This is due to a combination of anatomical as well as pathological factors. For example, in patients who have some dietary deficiencies in terms of fiber, there can be increased intraluminal pressure with straining, and at the areas of anatomical weakness of the large bowel wall, for example, in some areas where the outer layer of the muscularis propria is not complete, and coupled with the same areas where there is penetration of the vessels and nerves into the wall of the colon, these are the weaker areas which are prone to form diverticula. In the Western population, these often occur in the left colon, for example, in the sigmoid colon. However, in the East, they can also occur in the right-sided colon. So in summary, this is an example of diverticular disease where we can see pseudo-diverticular as outpouchings into the wall of the large bowel. This may be complicated by obstruction in terms of the fecal material that gets entrapped in the diverticula, as well as diverticulitis, inflammation, perforation, and possibility of pericolic abscess and fistula formation.